Hi, my name is Alan Hirahara from Sacramento, California. We're talking today about BioCartilage Micronized Cartilage Matrix. Now, Micronized Cartilage Matrix, it has the potential to augment microfracture, so we call this the Microfracture Plus technique. It does provide the cartilage ECM scaffolding and does allow for bone marrow stem cell attachment and growth. The stem cells are exposed to the ECM and they'll differentiate based on factors present within the matrix. There's been studies, for example, by Cheng in 2009, looking at adult stem cells seeded onto lifelized cartilage scaffolding. This allowed for chondrogenesis and actually resembled native articular cartilage. But what is BioCartilage? Well, BioCartilage is an allograft cartilage extracellular matrix. It contains key components of cartilage, specifically type 2 collagen, proteoglycans, and additional cartilaginous growth factors. Now, BioCartilage is processed by dehydrating it, then micronizing it. The final particle size is about 100 to 300 microns, and it's aseptically packaged, and it's actually available for a shelf life of up to 5 years. It doesn't require any special storage, just ambient temperature storage is adequate. Now, BioCartilage's intended use is really to help as a scaffolding in a microfracture defect. So this is not to re-implant new cartilage. It's just to allow as a scaffolding for the stem cells to come and differentiate and create new hyaline-like cartilage, not that this cartilage will actually take, so there's no live cells. The goal is to improve the tissue quality that forms after the microfracture and prevent fibrocartilage formation and actually get hyaline cartilage formation. Now, there's been in vivo support of this type of process. For example, Malinin took a look at baboon osteochondral defects filled with micronized cartilage particulate, and by 9 weeks saw hyaline-like cartilage formation. This control group had remained open and contained uneven patches, but the actual study group showed very nice filling in. Now, the Microfracture Plus with allograft tissue does work, and there's been other in vivo support as well. There's been a rabbit model looking at femoral condyle defects, and they showed, Chanda that is, in treatment group had persistent upregulation of cartilage phenotype markers, specifically type 2 collagen and aggrecan. Now, there have been other products that looked at these types of problems, and one of the products like De Novo has been used they use juvenile allograft cartilage. It's minced into 1 millimeter cubes. Now, this is actually live cells, and the packaging is much more expensive. So instead of $750, you're talking about $4,500, and the shelf life is only about a month. And arthroscopically, it's having to be done open as opposed to with a scope. Other types of processes like ACI have been used. However, it requires 2 surgical procedures, and the expense is much more significant in the realm of $16,000 just for the actual process, not including the 2 surgeries themselves. And this requires biopsy, culture, and implantation. But the Microfracture Plus does have a precedence. In Europe, there's something called BST Cargel, and this has been done now for the past year. And they have shown that after a 12-month follow-up from an MRI, you do see a significant increase in the fill, and that when actually second look arthroscopy has been done, you actually do see more cartilage in the area, as well as a better qualitative type of cartilage in the region as well. So there is a precedence. The relative cost we've talked about already. There's a significant difference in the different types available out there. This, however, is a more economical solution and has potential to be easier on the patient, does not require 2 surgeries, and can be done arthroscopically. If you look at how many cases are done in a year, there's over 130,000 cases done per year of marrow stimulation, that is microfracture. And that's significant. And if we can actually get these to be effective as opposed to just potentially a temporizing solution, we're going to have a much better outcome on our patients. Now, here's an example of one of the cases that we've looked at. This is an actual humeral head defect in the shoulder. Now, the key point here is that you have to have clean margins, nice clean edges of margins. If it's a defect that's very diffuse, it's not going to work. You have to have nice margin, nice clear defect, and then after performing your microfracture, you're going to have to do this in a very dry environment. You have to get all the water out. And then you have to introduce, after your microfracture, that biocartilage into place. Once that's done, it has to be smoothed over and fill the defect very nicely so it has a nice clean edge to it. Once that's done, and you now have everything smoothed over, it's now ready to be sealed in place. And all you have to do is take a fibrin coating and coat it with a fibrin layer. And once that fibrin gel is in place, that'll seal in place. The goal here is to prevent synovial fluid from infiltrating to the area and allowing the stem cells to come up and form actual hyaline-like cartilage and replace your scaffolding of BioCartilage with its own specific hyaline-like cartilage. Here's a case presentation of a reverse Hill-Sachs lesion that I did last year. Arthroscopically, you see on the right what it looks like, and on the left you see the actual MRI evidence of the actual defects of both cartilage and some bony defect. During the surgery, the BioCartilage was implanted after a microfracture, and approximately 3 months later, post-op, we saw these results, and it was quite amazing. So in addition to the cartilage being replaced, the actual bony defect actually filled in as well. Another presentation we have is of a glenoid lesion, and we see that here there has a full thickness defect with nice margins filled in with the BioCartilage scaffolding. But the question always comes up, how should we do it? Well, it's quite easy to be done open, it's inexpensive, and it's quick. Something can be done quite simply with a simple procedure. However, arthroscopy is absolutely possible. It's challenging. You have to clean the margins very nicely with a burr or a curette, but instrumentation with the cannulas and the double lumen applicator is going to be necessary. Now it comes as actual particulate in this tiny little packaging. Once you add it to the tube, and then add approximately 1 cc of platelet-rich plasma, you can then go ahead and mix it. And what happens is it's now ready to be inserted through the applicator. You have to have the fibrin ready. One of the key points is have everything ready to go because you don't want the water to fill in. So using that double lumen system for the fibrin glue is going to be critical. And don't use too much. Using cannulas is another critical point. You have to have quick, easy insertion. This has to be efficient. If it takes too long, too much water is going to fill up. And you have to have good vertical margins. So if you're going to use a curette, be careful not to use divots, and using burrs can be difficult. So you have to make sure you get that curette or burr to make sure you have nice, clean margins. You have to suction out and keep it dry. And lastly, don't overhydrate. 1 cc of PRP to that paste is what you need. If you're going to do it arthroscopically, you have to make it very, very tacky and very, very dry. Thank you very much.